Okay, let's dive right into this explainer. Today, we're taking a deep look into the clinical realities of psychotic disorders. We're going to treat this incredibly complex subject with the empathy, the clarity, and the scientific rigor it really deserves. My goal here is to teach, to break down exactly what's happening in the brain, how clinicians actually identify it, and how modern science steps in to help.
Here is our syllabus for today. First, defining the symptoms. Second, the DSM-5 diagnosis. Third, delusions and hallucinations. Fourth, the causes of schizophrenia. And fifth, modern treatment and support. So, before we get into the weeds, I think it's crucial to ground ourselves in what a psychotic disorder actually entails, clinically, way beyond the common societal misconceptions. At their core, these are conditions characterized by a very specific triad of symptoms: positive, negative, and disorganized. And our main focus today, which is also the primary focus of the DSM-5 criteria in this area, is schizophrenia. Section 1. Defining the symptoms: positive, negative, and disorganized. To really wrap our heads around this, let's use a simple math analogy. When clinicians say positive symptoms, they absolutely don't mean good. It means addition. It's an excess or a distortion of normal function. So things are being added to a person's reality, like hallucinations and delusions. Conversely, negative symptoms means subtraction. It's a deficit, a loss of a normal function that, should ideally be there. The deep, often invisible toll of this disorder really lies in those negative symptoms, the subtractions we just talked about. We see flat affect, which is a severe reduction in emotional expressiveness. There's alagia, essentially a poverty of speech. Avolition is a profound clinical lack of motivation to do anything, really. And then we have anhedonia, the sheer inability to feel pleasure, right alongside asociality, a complete withdrawal from social interactions. These deficits can be incredibly debilitating, yet they somehow get way less public attention than the positive symptoms. Beyond positive and negative, we also see disorganized symptoms. This is where the very structure of thought and physical movement becomes severely fragmented. Disorganized speech might show up as loose associations, jumping between entirely unrelated ideas, or tangentiality, where a person just drifts completely off topic. At its absolute most severe, it becomes what we call a word salad, where sentences are entirely incomprehensible. We also see grossly disorganized or even catatonic physical behavior, where a person might completely freeze up or show highly inappropriate motor responses. Section 2. The DSM-5 diagnosis, the clinical checklist. Now, diagnosing this isn't guesswork. It's a very specific, rigorous clinical checklist. A doctor is looking for at least two of the following: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, or negative symptoms. But here's the critical rule to remember. To meet the criteria, at least one of those two symptoms must be from the first three on this list, meaning a patient absolutely has to exhibit either delusions, hallucinations, or disorganized speech. Let's look at the timeline, because a diagnosis isn't just made after a single day of symptoms. The DSM-5 requires that active symptoms, that intense phase we just outlined, be present for a significant portion of time during a full 1-month period. Furthermore, continuous signs of the disturbance, which can include the milder prodromal onset or residual periods, they must persist for at least 6 full months. It is absolutely vital that these symptoms cause significant social or occupational dysfunction. It has to profoundly impair a person's daily life, their ability to work, or their relationships. And crucially, the clinician has to rule other things out. The symptoms can't be better explained by a mood disorder with psychotic features, and they can't be the physiological result of substance use or some other underlying medical condition. You've probably heard terms like paranoid schizophrenia or catatonic schizophrenia in movies or older books, right? Well, modern science has actually evolved past that. The DSM-5 removed these subtypes entirely. Why? Because they simply had really poor clinical reliability and stability over time. A patient might look paranoid 1 month and then disorganized the next. So instead of boxing patients into unstable subtypes, clinicians now use dimensional severity ratings to capture the unique flowing nuances of every individual's condition. Section 3. Delusions and hallucinations. Categorizing the experience. Let's focus on delusions for a second. These are fixed, false beliefs that completely resist all reason, and they can take a lot of thematic forms. Persecutory is the most common, that intense belief that one is being harmed or harassed. But there are plenty of others. Grandiose delusions involve believing you have exceptional abilities or fame. Referential means believing completely neutral, everyday environmental events are directed specifically at you. We also see erotomanic, believing someone is in love with you, somatic delusions regarding bodily functions, delusions of control where you think your thoughts are being inserted or withdrawn, all the way to nihilistic or Cotard's delusions, where a person believes a major catastrophe will occur or even that they're already dead. Similarly, hallucinations, which, to be clear, are sensory perceptions without any actual external stimulus, can span all 5 of our senses: visual, tactile, olfactory, and gustatory. However, auditory hallucinations are by far the most prevalent, and specifically, these often manifest as voices that are constantly commenting on the person's behavior, or worse, actually commanding them to do things.
Section 4. The causes of schizophrenia, the diathesis stress model.
I want you to think about the number 48. This represents the massive 48% genetic concordance rate in monozygotic or identical twins. Basically, if one identical twin has schizophrenia, there's a nearly 50% chance the other will too. Compare that to just 17% in dizygotic or fraternal twins. This proves a massive, undeniable genetic link. The closer you are genetically to an affected relative, the higher your risk.
But genetics aren't destiny, which brings us to the diathesis stress model. There are 4 core pillars to how the disorder develops. Diathesis means a biological vulnerability, which includes the genetics we just mentioned, neurochemical imbalances, and neurodevelopmental issues such as prenatal viral infections, obstetric complications, or structural brain abnormalities like enlarged ventricles. The stress part, that's the psychosocial column. The disorder often activates when that biological vulnerability collides with environmental triggers, things like an urban upbringing, migration, adolescent cannabis use, or high-stress environments.
Drilling down into that neurochemical pillar, the leading theory is the dopamine hypothesis. This theory teaches us that excess dopamine activity, particularly in the mesolimbic pathway of the brain, is directly linked to driving those positive symptoms like hallucinations. And this isn't just a wild guess. It's highly supported by the fact that dopamine-blocking drugs actively reduce psychosis, while dopamine agonists, like amphetamines, can actually induce it. Science is also increasingly pointing to the hypofunction of glutamate receptors as another massive piece of this chemical puzzle.
Let's jump back to the environmental stress side with a really crucial concept, expressed emotion, or EE. In a clinical context, families exhibiting high EE show high levels of criticism, hostility, and emotional over-involvement towards the patient. Teaching families about expressed emotion is vital because being discharged into a family with high EE directly and powerfully predicts a patient's risk of relapse. It's a highly actionable piece of data that proves just how much our everyday environment matters.
Section 5. Modern treatment and support, antipsychotics and psychosocial care. So how do we treat it? Pharmacological treatment is historically divided into 2 generations. On one side, we have typical antipsychotics. These are your first-generation drugs like haloperidol. They work by bluntly blocking D2 dopamine receptors, but they come with a high risk of extrapyramidal side effects, which are severe motor and muscle control issues, including tardive dyskinesia. On the other side, we have atypical or second-generation antipsychotics like clozapine. These have a broader receptor action, and they're actually better at treating those tricky negative symptoms we discussed earlier. But they trade the motor side effect risks for different ones, most notably weight gain and metabolic syndrome. But as we've learned today, medication alone, it simply isn't enough. Combining pharmacology with psychosocial interventions is how you actively help patients rebuild their lives. This includes social skills training to overcome the negative symptoms. It includes family psychoeducation, which directly targets and reduces that dangerous expressed emotion we just talked about. Clinicians also utilize cognitive behavioral therapy tailored for psychosis, assertive community treatment, and supported employment programs to reintegrate patients safely and productively back into society. We've explored the clinical anatomy of this disorder, from the complex math of its positive and negative symptoms to the intricate dance of genetics and environment that causes it. But the final, lasting question I want to leave you with is this. Knowing what we've taught today about the profound biological and psychosocial roots of schizophrenia, how can we apply this science to foster a more supportive, empathetic, and integrated world for those experiencing it? Thank you for joining me for this explainer today. Take this knowledge and keep exploring.